The next topic will be devoted to radiotherapy. Is locally advanced and oligo-metastatic prostate cancer radiotherapy. Speaker Ruduša, radiation oncologist from Riga East University Hospital, from Oncology Center, Latvia. Please.
Thank you very much for the introduction. And as I was introduced, I am Ruduša, and I would like to thank the organizers for the invitation and the opportunity to present this topic. I have no conflicts of interest to declare, and we'll carry on. We'll begin with the definition of what is locally advanced prostate cancer, because sometimes it can differ depending on the information source, because some say that any T-stage but with involved lymph nodes is considered locally advanced prostate cancer, but in some sources, locally advanced cancer includes clinical stage T3, T4, sometimes even T2C bulky tumors with no metastasis in the lymph nodes and no distant metastasis. But nonetheless, the preferred treatment is androgen deprivation therapy, as we all know, unless it's medically contraindicated, with combination of local treatment, and it is radiation therapy. And here we have several options. It could be brachytherapy, that is for the local tumor, for the prostate cancer. It could be external beam radiotherapy, which I'm going to concentrate more on, and also it could be SBRT. And because these patients have a disease that is unlikely to be completely removed surgically, that's why the preferred treatment is non-invasive or minimally invasive in case of brachytherapy. The NCCN guidelines divide prostate cancer in risk groups, as we all know, and in many publications, advanced prostate cancer includes both high and very high risk group prostate cancer. And according to the NCCN guidelines, ADT is required in locally advanced prostate cancer unless it's medically contraindicated. In external beam radiotherapy, clinical treatment volumes include the whole prostate gland, the seminal vesicles, and the pelvic lymph nodes, depending on the risk of involvement, and I'm going to talk about this a bit more in the upcoming slides. The planning target volume margins that we use for prostate cancer, for the prostate gland and seminal vesicles, are 7 millimeters in all directions, except posteriorly, where it is 5 millimeters, to reduce the radiation dose to the rectum and to avoid toxicity. In this table, you can see the preferred dosing regimes according to the guidelines that we use in our clinic. And as you can see, for locally advanced prostate cancer, the preferred treatment regimes are hypofractionation, moderate hypofractionation. Why? Because prostate cancer has a low alpha-beta ratio that describes the low proliferation rate and very good results with reduced fraction sizes. As you can see here, 20 fractions, 26, 28. But you can also use conventional fractionation by 1.8 till 2 grays per fraction. And for very high and high risk groups without nodal involvement, you can also use ultra hypofractionation, also known as SBRT. And our clinic uses 5 fractions. Talking about prophylactic nodal radiation, sometimes it is indicated in patients with high and very high risk. In those cases, the clinical target volume includes lymph nodes from the L5-S1 interspace, where low common iliac lymph nodes are located, to the top of the pubic symphysis, where the obturator lymph nodes are located. Also, presacral lymph nodes are included, and the planning target volume margin is 7 millimeters. And of course, we exclude bone structures, muscles, bladder, and loops of bowel if they are not involved. The dosing is 1.8 till 2 grays per fraction, with a total dose of 45 till 50.4 grays. And how do we decide which patient is going to get prophylactic nodal irradiation? We use the risk assessment with the Roche formula. It is a risk calculator where you insert the patient's PSA level prior to treatment, also Gleason score, and the calculator does everything for you and shows how high is the risk of possible lymph node involvement. If it's higher than 15%, then the patient should get prophylactic nodal irradiation. But this formula can also be used to assess the risk of prostate capsular penetration as well as seminal vesicle involvement. So it has several possibilities of use, not only lymph node involvement risk assessment. Here you can see the visual representation of pelvic lymph node contouring. Here you can see the external, internal iliac lymph nodes contoured, also the presacral ones, and as I've mentioned, we avoid the bowel loops, we avoid bony structures and also muscles, because these structures do not need to receive any additional radiation dose. And the European Association of Urology does not recommend prophylactic nodal irradiation because randomized controlled trials didn't show any benefit, and they have the stance that more randomized clinical trials need to be performed. And more trials are carried out. With every upcoming year, more and more of them are seen. And for example, this is a phase 3 randomized clinical trial from last year that compared prophylactic nodal irradiation to prostate-only radiotherapy. The total number of patients was 224, and they were divided into two groups. One group received prostate-only radiotherapy, while the other one received both radiation to the prostate as well as whole pelvic lymph node regions. The lymph nodes received a total dose of 50 grays. The median follow-up was 68 months. The primary endpoint was 5-year biochemical failure-free survival, and the secondary endpoints were disease-free survival and overall survival. And the results were in favor for the prophylactic lymph node irradiated group. It showed a statistically significant improvement in 5-year biochemical failure-free survival, where you can see for the prophylactic lymph node group it was 95%, as well as for disease-free survival it was 89.5% compared to the group that received only prostate radiotherapy of 77%. Unfortunately, the overall survival did not appear to differ among the groups, and so this trial concluded that prophylactic irradiation for high risk and locally advanced prostate cancer improved biochemical failure-free survival as well as disease-free survival. But we still need additional publications and additional trials. The European Urology Association was also cautious about the use of SBRT in high-risk prostate cancer patients, but the publication from last year showed that patients after SBRT had a 4-year biochemical recurrence-free survival of 81.7%. And similar rates were seen in similar trials where patients received brachytherapy boost or dose-escalated conventionally fractionated radiotherapy alone, of course in combination with ADT. The overall toxicity rates were low, and they were quite similar to patients in low and intermediate risk group who received SBRT. So preferably we need additional data to exclude the effects in the follow-up and late toxicity rates. But if we have a situation where the patient has regional nodal disease, meaning metastasis in the lymph nodes, then of course radiotherapy is indicated. And the gross nodal disease should receive a higher dose. If I mentioned before 50 grays, then here it is not enough. You need to administer more radiation, preferably 60 grays or even more, of course, while maintaining normal tissue constraints. Otherwise, we will have greater toxicity and no improvement on the quality of life. The dosing is 46 grays in 23 fractions to the whole pelvic lymph node region, but we give additional dose to the enlarged lymph nodes, the so-called boosting, and usually we use simultaneously integrated boost, meaning that we administer the same number of fractions, only we elevate the dose to our desired regions. The clinical target volume in this case starts at L4, L5, or L5S1 interspace, or one vertebral body above any radiographically involved lymph nodes. So if the enlarged lymph node is above the level of L4, L5, let's say, then we're gonna, of course, include it higher up. The presacral nodes also are included, and yeah. Why should the dose to the lymph nodes be 60 grays or above? Because dose escalation improves biochemical recurrence-free survival, relapse-free survival, and also distant metastasis-free survival without increasing severe adverse events. And as it was shown in this publication from Japan from year 2020. In this publication, all patients received whole pelvic irradiation of 40 till 46 grays, so a bit less than we usually give, and the prostate region received 72, 78 grays in a daily fractional dose of 2 grays. And the metastatic lymph nodes had a dose escalation, meaning they received around 60 grays. And it showed that dose escalation to the involved lymph nodes significantly improved relapse-free survival and distant metastasis-free survival at 7 years after treatment, where it showed a statistically significant improvement. So it shows that you need quite a long follow-up period to see any improvement. And now I will go on to the other part of my presentation about oligo-metastatic prostate cancer. It includes less than 3 to 5 metastases outside of the small pelvis. And here as well, we can see some discrepancies upon the definition of oligo-metastatic prostate cancer. In 1995, the duo of Dr. Wechselbaum and Hellman proposed the term oligometastasis or oligometastatic state. And they defined it as an intermediate, or you could say a transitional state between widely disseminated and initial metastatic state with low spreading capacity. And that's why this is a group of patients where local ablation therapies may cure this oligometastatic disease. Unfortunately, as I've mentioned, there is no consensus definition for oligometastatic disease and prostate cancer, and this table shows that different trials have very different definitions of oligometastatic prostate cancer. They have different locations of metastasis, different numbers of lesions, the castration status is different, and also, which is very important, the imaging modality that is used to localize metastasis as well is different, because there are publications showing that PSMA PET is a better diagnostic tool to use than, let's say, FDG PET and Holin PET. And you can diagnose metastasis earlier on, so you can administer local therapy earlier on to avoid the addition of ADT and to reduce the toxicity and improve the quality of life. Patients with metastatic cancer typically receive systemic therapy, and local treatment is reserved only for symptom palliation, but in the last years, the situation is changing. Why? Because there is a theory that the primary tumor needs to prepare the niche where it's going to spread, and you could compare it to priming the soil before putting in seeds. That's why local treatment, both of the primary tumor, inhibits not only the progression of the disease, but also the progression of already existing metastases. And sometimes you have the reduction in size of these distant metastases, and you could explain it through the abscopal effect that is from the radiation. The spectrum of metastasis that can be treated with radiation is quite broad. You can use it for bony lesions, lymph nodes, metastasis in the brain, lungs, liver, and even adrenal glands. So there's a quite large spectrum that we can use radiation. The NCCN guidelines define oligometastatic prostate cancer as low volume, and according to this, radiotherapy is an option if the patient has good performance status and has no contraindications to receive radiotherapy. For example, 10 to 20 years ago, a cardioverter or implanted cardiac device was a contraindication for radiotherapy. Then currently, analyzing each situation individually, you can treat these patients with radiotherapy. And of course, ADT is indicated unless it is medically not possible. And it's always important to minimize the toxicity when delivering radiotherapy to the primary lesion. And before, it was uncertain if treatment of metastatic lesions was beneficial, but now there's data that confirms it. And this is Stampede trial that was mentioned before many times, but I'm gonna look at it from the radiation oncology perspective. It was published in 2018, and you're all familiar with it. The Stampede trial added radiotherapy to metastatic cancer patients in two types, with moderate hypofractionation in 20 fractions or in weekly fractionations, meaning they administered 6 grays once a week and 6 weeks following. And the radiotherapy was well tolerated. The adverse events were around 5% during treatment, and after finishing, even less. and it improved failure-free survival, but not the overall survival. It didn't show any statistically significant improvement. However, additional analysis showed that prostate radiotherapy did improve the overall survival by 8% at 3 years following treatment, from 73 till 81% in a subgroup of patients, and mainly in those that had low metastatic burden, which represented around 40% of the comparison population in this trial. Here you can see the charts with statistically significant overall survival improvement in low metastatic burden, where you can see in high metastatic there is no improvement, but here the addition of radiotherapy did improve overall survival in this subgroup of patients. As well as same goes for failure-free survival, where it showed statistically significant improvement in a subgroup of low metastatic burden patients. The incidence of acute bladder and bowel toxicity was lower for weekly schedule group, the one that received 6 grays in 1 fraction per week, than for the daily schedule, and it makes sense from the radiobiology perspective because the normal tissues have the time of 1 week to recover the sublethal damage that it cannot completely do in a daily fractions schedule. Concerning the delayed toxicity scores, the overall scores were quite low. Even the radiotherapy group received only around, showed only around 4% of late toxicity. The NCCN guidelines do not recommend dose escalation beyond the biologically effective dose equivalents that were used in the STAMPEDE trial, because this trial showed that these 2 types of fractionation are safe to use, and that's why you need to be cautious if you want to administer even larger biologically equivalent doses. Why? Because it may lead to increased toxicity without overall survival improvement, and that's not in our interest. The planning target volume includes the whole prostate gland with 8 mm margin posteriorly to reduce the dose to the rectum, and 10 mm everywhere else. And in our clinic, we usually use a bit lower PTV margins, 5 and 7 millimeters, and if we use SBRT, then 3 and 5 millimeters. This table shows the preferred regimes for low volume metastatic prostate cancer, the ones that were used in the STAMPEDE trial, and those can be used. I'll say a few words about administration techniques because in radiation oncology we have a lot of abbreviations, so it should be clear to you. Historically, 3-dimensional conformal radiotherapy was used, but nowadays IMRT and VMAT are the main techniques used. And here in the pictures you can see why. The red means high dose regions, while the yellow color represents intermediate high dose regions, and the dark blue are low dose regions. So with newer technologies, we can achieve high dose to the prostate and spare the normal organs, meaning the rectum and the bladder. They receive a smaller dose, and that's how we can reduce the toxicity. Image-guided radiation therapy is the main source nowadays. You can use portal Kiwi images, which look like X-ray pictures if you have fiducials implanted, but we use onboard imaging with cone beam CT every single day to perfectly position the patient. And here in the panel on the right, you can see why patient needs to prepare for the treatment. If we have an empty rectum, then the prostate is located as we planned. But if the rectum is full of content, then it pushes the prostate anteriorly, meaning that both the rectum will receive a higher dose and prostate will receive a lower dose than we planned initially. So we can have a larger probability of toxicity from the rectum. And for example, if we have gas in the rectum, it causes artifacts and we cannot visualize the prostate well enough. That's why preparation is very important. Talking about immobilization, the patient is in a supine position with comfortably full bladder and empty rectum, and we usually use vacuum bags or leg positioners. Diagnostic MRI and PET-CT images are very valuable and should be always used if available. And our clinic currently has 5 linear accelerators that treat patients. And for prostate cancer, we usually use TrueBeams and Novalis because they have this cone beam CT and also VMAT technique available. And here in the picture, you can see one of the Linux that was installed in 2019. And what kind of techniques we can offer? Almost all the spectrum. And is there a benefit from additional radiotherapy to oligo-metastasis? This article from 2020 answers that yes, it is a benefit. Patients with oligo-metastatic disease received radiotherapy for 5 weeks with a total dose for the prostate and seminal vesicles for around 69 grays. And the metastatic burden received a bit different dose. The bone lesions somewhere around 45-55 grays, the lymph nodes higher, till around 60 grays. And the overall survival was almost 69 months. And PSA at first follow-up was the most important prognostic factor. And that group of patients who had PSA level of less than 1 nanogram per milliliter had better biochemical relapse-free survival. But more trials with longer follow-ups are still needed. And now I will show you a few cases from our archive how these patients are treated. This is a male of 70 years with prostate cancer of T3A and Gleason 4+5 after radical prostatectomy in 2019. Unfortunately, he had a biochemical relapse and he received whole pelvic irradiation till 50 grays. As you can see here, the lymph nodes received 50 grays and the postoperative bed received 64 grays. And we used the VMAT technique, the newest ones. As you can see here, the gantry of the linac moves in an arc pattern. The same patient later on returned with painful bony lesions on the left side, and for that region he received palliative radiotherapy. This is one of the most classical regimes that you can use, 10 times 3 grays with a total dose of 30 grays, as well using VMAT technique. This is a 72-year-old patient with prostate cancer with a metastatic lesion in the 4th lumbar vertebrae. He received SBRT in 3 sessions with a cumulative dose of 30 grays. So quite a small lesion. That's why it could be used for SBRT quite well. And sometimes we cannot use SBRT even though we want to, if the lesion is located too close to the skin surface or too close to the kidneys, because we cannot fulfill the dose constraints for that location. That's why each and every single situation and patient is analyzed on an individual basis, and we offer the best treatment that we can perform. And this is a 65-year-old prostate cancer patient with nodal metastasis as well as metastatic rib lesions. He received whole pelvic radiotherapy of 50 grays, but as you can see here, these orangish reddish lymph nodes are enlarged, and they received the simultaneously integrated boost till 60 grays. And here I will show you how it looks like. At the level of the kidneys, we have enlarged lymph nodes, and the red-orange color means higher dose delivered to these lymph nodes, and the blue doses are lower, that is covering the other parts of the lymph node region to reduce the possibility of disease spread later on. And this is how the plan looks like, the coverage. And as I've mentioned before, we try to avoid the normal structures, the rectum and the bladder. Of course, they will receive some dose, but we always try to include the dose constraints to fulfill them to avoid any unnecessary toxicity. And this same patient had FDG PET-CT performed. That's how the bone lesions were found. And it shows metabolically active metastatic lesions in the 6th rib on the right side. Here is the one lesion, and here's the other one. Here you can see the metabolic activity from the liver. That's why it shows up here. Both bone lesions received SBRT treatment of 5 fractions with a total dose of 40 grays. And this is a good example of why we cannot use larger doses and less fractions, because we have the chest wall, which is also an organ at risk, you could say, as well as the lung. That's why we cannot administer very large doses. But still, 5 fractions is very good, and usually the treatment result, the outcome is quite good, as I've mentioned before, because prostate cancer has a low alpha-beta ratio, so they react to hypofractionation better than, let's say, cervical cancer or head and neck cancer that has an alpha-beta ratio of 10. So prostate cancer has an advantage, you could say. And these are my take-home messages that I would like you to remember from this presentation. And it is that SBRT can be used in high-risk prostate cancer patients with favorable toxicity and efficacy profile. Prostate radiotherapy should be a standard treatment option for men with newly diagnosed disease with low metastatic burden, and prostate radiotherapy improves the overall survival as seen in STAMPEDE trial by 8% at 3 years after treatment in patients with low metastatic burden. This is my list of references, and thank you very much for your attention.
Thank you very much for your very informative lecture, and good luck for the radiation oncologist in Latvia. And we have some questions. Please, colleagues.
Yeah, I want to ask approximately how many SBRT to lymph nodes cases you had in oligorecurrent prostate cancer in your department?
I do not have the exact data, but somewhere around 3 to 5 cases definitely per year. That's an approximate number.
And what usual dose for this limited lymph nodes meds you deliver?
Here also, usually if the lymph nodes are enlarged, We use conventionally fractionated with the simultaneously integrated boost with a total dose of 60 grays. For SBRT, we are a bit more cautious to use it currently, but in due time, hopefully we're going to use it more and more for lymph nodes as well. But the cumulative dose should be around 60.
For oligo-metastatic disease in lymph nodes in our clinic, usually we treat by 6 gray per fraction in 5 fractions. Maybe you use higher doses. I talk about SBRT.
Yes, about SBRT. I do not have the exact data, but I think it's similar, not higher.
Okay, thank you for nice presentation.